So if you did.
Yes, so for pulmonary aspiration, it was not documented in the notes that was on the differential. They were more so operating on pneumonitis, which or pulmonary hemorrhage / pulmonary edema. For the IUD, a Paragard was replaced at the end of the case. After the dislodged IUD was removed, it was just inserted intraoperatively.
So I just have 2 points. One, what was the deficit? You said 1,300, correct?
1630.
So maybe you can address the incidence of pneumonitis from a 1,600 cc normal saline deficit, which is not that much. And the other thing is, why didn't we try to put the IUD in under ultrasound guidance, as this was already, it's possible that this was placed incorrectly the first time when it's done without sight.
So I don't know the exact incidence of pneumonitis or pulmonary edema with a deficit of 1630, but I know with normal saline, we do worry about pulmonary edema. The upper limit of acceptable deficit is 2,500 cc's. My understanding is that this entire case was done under ultrasound guidance, and that the IUD was placed under ultrasound guidance in the OR.
Okay. Would you, in the future, stop a case when you have a 1,600 deficit, a normal saline, normally?
No, especially since the note from the nursing was made that there was the majority of the deficit was on the floor from leaking from the operative port of the hysteroscope.
I'm just saying, I think that this most likely was not a hysteroscopic complication, but more likely an anesthesia complication. And that just should be noted for everybody, that you don't have to stop a case at 1,600 normal saline deficit. That would be my point.
Actually, I'm curious, Gabriella, is there a final answer when you discuss this case with a senior anesthesiologist? Are the lung findings compatible with confirming that it was laryngospasm, or when someone looks back at this case, does it look like it wasn't laryngospasm and it was pulmonary edema or pneumonitis or something like that? What's the final answer is what I want to know.
So there is no final answer. The only way to definitively diagnose laryngospasm is to visualize the closing of the glottis during the episode. It was not documented that was done, and that's also difficult to do when you're trying to open an airway. So there's no final answer, honestly.
Hi, it's Ron. May I speak?
Yeah.
So in doing hysteroscopic procedures for years, I've found that there's really no need to keep the saline infusion going the entire time unless you're actually doing something. So for instance, if you start the case, you get your visual, there's nothing wrong. Let's say you need instruments brought into the room or whatever. You can turn off the suction exit from the hysteroscope and then turn off the inflow. The image will remain in place. The endometrial cavity will remain distended to the point where you can do whatever it is you need to do in the way of waiting for equipment, etc. And then you turn on the inflow and adjust the suction appropriately. And I found over the years, this really dramatically reduces the amount of deficit at the end of the case. Now, granted, here you may have had some on the floor, but in working with many of the resident staff over the decades, I have found that they just don't seem to do that. They seem to keep the fluid going the whole time. And I would encourage, Gary, if you could, discuss this with them at some point. There are ways to limit inflow. And that's all I wanted to say.
All right. Well, thank you. And with that, we're just about out of time. So thank you, Gabriella. Excellent job with these two cases. And in a moment, I'm going to ask Dr. Ayers to introduce our grand round speaker. But in the meantime, my standard announcements will be taking attendance using the participants list at 8:10. If you are a phone number or some other reason why we can't identify you from the participants list, please feel free to email me or Michelle with your attendance. And the attendance code will also be distributed via the email system. And with that, Dr. Ayers, are you ready to introduce our speaker?
Yes, Dr. Eber, can you hear me?
Yes, loud and clear.
Thank you. Good morning, everyone. Welcome to Grand Rounds this morning. And our Grand Rounds speaker today is Dr. Sarah Temkin, Associate Professor of Clinical Research of the Office of Research on Women's Health at the National Institute of Health. Dr. Temkin is a gynecological oncologist who earned her medical degree from Georgetown University, completed her residency in obstetrics and gynecology at Mount Sinai, and completed a fellowship in gynecological oncology at Sani Downstate Medical Center. She has been active in clinical research throughout her career with recognized expertise in clinical trials. Dr. Temkin has served as an investigator for novel therapeutics, supportive care interventions for women in ovarian, endometrial, and cervical cancers. In addition, Dr. Temkin has contributed to the national conversations about cancer prevention, and equity in cancer care. She also provided a voice for equity in the physician workforce, specifically attuned to the unique challenges of women surgeons and gynecologists. We look forward to hearing this thought-provoking presentation, When Surgery Becomes Women's Work, Gender Stereotypes and the Feminization of Gynecology Workforce. Dr. Temkin, welcome.
Can you all hear me well?
Yes, we can.
And then I'm going to share my screen. All right, I'm sharing my screen. Are you seeing the correct view?
Yes, we are.
Yes.
Okay, perfect. So thank you so much for inviting me to talk today and for your warm welcome and letting me listen in on your morbidity and mortality conference. It is good to know that there are active discussions happening everywhere. And so with that, I'm going to talk a little bit today about, hold on, I have no disclosures. I'm going to talk a little bit today about my thoughts about gender and OBGYN, and this is a little bit some reflections on my own career and what I've seen happen to the field over the last few decades. So within the modern era of medicine, I think we all know that women began entering medical schools in the 1970s. This was spurred by mainly by the Title IX Act that prohibited discrimination based upon gender in higher education. And although we think about this typically as having to do with women, allowing women into sports, this had a profound impact onto medical education. Before Title IX, there were quotas on women entering medical school, which were capped around 8%. And by 1980, 30% of medical students were women. And actually, this trend continued. And for nearly 2 decades, we've had equal numbers of medical students be women and men. We see equal attrition. We see equal entry into medical school and matriculation from medical school by gender. And despite the 50 years of significant numbers of women in medical schools, as you move up the hierarchy in healthcare, there are fewer and fewer women. The number of medical school deans that are women has been stable around 18% for over a decade, and the likelihood of promotion from associate to full professor or appointment as a department chair at U.S. medical schools has really remained unchanged when you look at the proportion of women entering medical school to the proportion of women holding leadership positions. The chances of an individual woman being promoted has really not budged. And I just put this last figure in here just to show you in terms of leadership in the C-suite, even in nursing, which is more than 90% made up of women, chief nursing officers are 40% of chief nursing officers in hospitals are men. In 2018, the National Academies of Science, Engineering, and Medicine reviewed the workplace environment for women in STEM fields, and I think this made a pretty big impression on a lot of people. Significant proportions of women experience harassment that's directly related to gender. And as you can see in the larger figure here, that nearly half of female medical students have experienced sexual harassment before they have even finished medical school. These rates of sexism and experience of harassment is higher amongst medical students than any other STEM field. in our society, salary is also a reflection of the value that we place on work. And for this more stressful, less supportive work environment, women physicians are paid less than men. The gender wage gap for physicians is actually an outlier. There are very few professions where women make more money than men on average, and physicians, as you could see, we're breaking the curve here, where there's a larger gender gap than in salary than in other fields. And the AAMC broke this down, disaggregated by race and ethnicity in 2021. And you can see for every race and ethnic group, women are paid far less than men in medicine. So specific to OBGYN, I would say a lot of times we are accused of being outliers because of the number of women that practice in obstetrics and gynecology. This specialty is made up of more women than any other field, although pediatrics is a close second. The same is true of our subspecialties, and this just shows data from the SGO State of the Specialty Report in 2020 that demonstrates that amongst younger professionals in the field, women far outnumber men, and the SGO became a majority women professional society in 2020, also with 54% of the workforce being women. Advancement in women in OBGYN has been remarkably similar to that of women in other medical specialties. This data is a little bit older at this point, but it comes from 2016, where we saw that advancement to a chair position in OBGYN is really very similar to that of other fields. When you look at the proportion of women who trained in the field, only anesthesiology and diagnostic radiology have equal elevation of women into leadership positions compared to men. And we looked at this also recently in gynecologic oncology, where the leadership roles within gynecologic oncology really mirror that of the physician workforce. When you look at the fact that we have over 80% of our trainees being women, 70% of our fellows, it would be expected that we had higher rates of gynecologic oncology members in leadership positions that are women. The workplace culture and physician well-being for women in OBGYN may actually be worse than in other specialties. Most women who are gynecologists report having experienced discrimination in the workforce. This is a report from AAGL members from a few years ago that 2/3 of women report discrimination, and the overwhelming majority of this discrimination is felt to be related to gender. Amongst gynecologic oncologists, and the SGO does a nice job of publishing a State of the Specialty Report every 5 years. The women in gynecologic oncology have report more depression and suicidal ideation, feeling of stress, even seeking psychiatric help compared to men. And also for both men and women, this has been increasing. This was increased compared to 2015. The gender wage gap in obstetrics and gynecology was actually called out in that AAMC report from 2021, where OBGYN is the department specialty with the most full-time underrepresented in medicine faculty and with the most women. Yet when examining data from this department specialty across MD faculty by race, ethnicity, gender, and rank, salary inequities persist. And this list of specialties with the lowest wage gap shifts from year to year, and we're not on this list this year, but in 2020, OBGYN did make the list of Doximity's largest gender wage gaps. And so what is happening here? I think this has been a really interesting puzzle to try to unpack. When I was a kid of the 70s, the feminist theory of that time was we just need women to get into the workforce. Once we get 30% of women sitting at the table that will have gender equity. And yet, and this was something called the critical mass theory, that just by including women into the workforce, we would change culture. Yet we've seen from the data that I've just presented that inclusion has been insufficient. Advancement, promotion, and leadership opportunities are not equitable. There are high rates of perceived sexual harassment and gender discrimination that are related to gender bias, and there is a persistent wage gap in our specialty. And so to try to explain this, I'm going to talk for a little bit today about the social and structural factor that is called gender. Gender is a multidimensional construct that links gender identity, which I think most people think of primarily as gender, but gender includes more dimensions than just identity. It also includes gender expression, social and cultural expectations about status, characteristics, and behaviors as they are associated with sex traits. And so the other components of gender that I'm going to talk about today include gender roles and norms, relation, and power dynamics. And just to start with gender identity, which is the core elements of a person's individual sense of self as it relates to sex assigned as birth. I just use myself as an example. I have, and throughout my entire life, have identified as a woman, and this has affected many of my choices that I've made professionally and personally. When I was in medical school, I did decide that I wanted to be a surgeon, and I got a lot of, oh, that's very adorable. You are a woman, so you should be an OBGYN. And you know, that resonated with me because I do think that women deserve surgical care. And so it made sense, and I became an OBGYN resident. When I was an OBGYN resident, I was still very interested in surgery, and I and the work of the gynoncs that I worked with really resonated with me. And so, you know, I changed my tune to now I want to be a gynecologic oncologist. You know, this was again met with some resistance, like that's so hard and it's really depressing, and don't you like babies? And I think this has a lot to do with my own gender identity, both as how I was perceived and also how I made my choices. And so when I was first started thinking about this topic a few years ago, I went back and actually started reading some of my college psychology. I had been lucky enough to be in college at Cornell University when Sandy Bem was teaching women's studies. And so this sort of framed some of the foundational thoughts that I have on this topic. But one of the first things that Sandy Bem would teach her undergrads was about this 1974 study that she published looking at masculine and feminine personality traits amongst male and female participants. And this was all the way back in the 70s. And what she found was really, I think, surprising to a lot of people at the time, and still remains surprising when I talk about this with people. But what she found was that only about a third of people assigned male at birth had typical masculine type personalities, and only about a third of people assigned female at birth had feminine type personalities. And so I think some of the personality attributes that I think that we all think of as being more masculine, like being assertive or willing to take a stand or speak up, are some of the characteristics that actually made me very well suited for a career in medicine and a career in gynecologic oncology and as a surgeon. Gender roles and norms are standards of behavior that we as a social group define as appropriate for men and women. And in general, women are expected to be polite, accommodating, and nurturing, while men are expected to be strong, aggressive, and bold. And so I'm going to go through a couple things that, you know, are are perceived or expected of women that that don't really align very well with a career in medicine or in OBGYN or in a surgical or procedural field. Competence is a characteristic that we typically view as necessary for leadership as well as just the practice of medicine. But for women in procedural fields, this is a particular problem that's highlighted in this study that looked at how women are perceived and women surgeons are perceived as compared to men surgeons. And the study found that female surgeons were rated higher by participants in this survey study in warmth, but conversely, they were rated lower as having incompetence compared to male surgeons. We've also spent decades telling women to be more assertive in the workplace so that they'll get a raise or a leadership position, but assertiveness in women is actually socially risky. Assertive women are often perceived as angry, and anger in women is really a violation of a social norm where women are expected to be communal and warm and nurturing. So when women are assertive, they risk violating these gender norms. And it's actually quite rational for women to avoid being direct in their communication, or especially expressing displeasure or being critical in the workplace, because that to do so risks a penalty. And these are a couple of lay press books that I think are very illustrative of this concept, if people are interested in reading in their free time. Rage Becomes Her is one of these books, and Rebecca Traister, the journalist, wrote this book a few years ago called Good and Mad, that's about how anger is perceived amongst women. And the language that we use in everyday communication really it reinforces our presumptions that we have about gender norms and roles. Sarah Cooper, who was famous for her Trump impressions in 2016, wrote this. Also wrote a book that's entitled How to Be Successful Without Hurting Men's Feelings, where she describes some of these the language that we use to describe the same behavior in men and women as thoughtful or erratic, passionate or hysterical, confident or arrogant, a disruptor or disruptive, busy or just a team player. And this really leads to a vicious cycle for women who are high performers. This is sometimes called the abrasiveness trap, but women are more likely than men to get feedback from either their supervisor or from their peers that collaboration and being helpful is the thing that's most important in their behavior. And as a result, women focus on being perceived as collaborative rather than being confident or being viewed by their peers and environment as competent. So it's actually quite rational that women focus on this, but then this tends to backfire when women receive negative feedback, which they do and at rates much higher than men, that they are seen as being too collaborative, and they get criticized for this as well. Sorry, my computer's beeping at me. And this abrasiveness trap is also commonly called the double bind, which I think probably some people have heard. And the concept of the double bind is usually used to describe this vicious cycle of women in leadership, where women are expected to be nurturing, emotional, and communicative, but when women do these behaviors or perform in this way that's expected by our gender assumptions, they are viewed as less competent as leaders. And so when you put that into a physician body and particularly a surgeon's body, there are a lot of rules unwritten rules to try to follow. Women are told not to appear too angry, not to appear to be too decisive. You are supposed to remember to talk about your family and how you are nurturing. And you want to remember not to be too competent or let people think you're too competent, and appear feminine, but not too feminine. And of course, this is all while we're supposed to be taking care of patients, which is a lot of do's and don'ts to try to follow, and can be very exhausting. And before you say like, oh no, I don't, I grew up in a liberated household. I live in a blue state. Like we're not like that in our institution. These perceptions around gender norms and roles are really pervasive within our society. I just pulled two studies here to just demonstrate how pervasive they are. Stereotypical beliefs about individuals based on the basis of sex are held by equal amounts of male and female respondents in this survey, written by a survey done by Molly Carnes, and also Argavon Salas surveyed people in healthcare, both surgeons and non-surgeons, about their implicit associations of women with career and family, women and men in career and family, or as surgeons or family medicine doctors, and it was really near universal that men with surgery and career, and women were associated with family and family medicine or non-procedural medical work. And these gender norms and roles, the expectations persist even in OBGYN departments. In this study, the medical student environment was looked at within OBGYN departments, and male medical students were more likely to be allowed during their clerkship to use the Bovie, suture skin, and use a cervical dilator or do procedures. And so we focus a lot on the medical student experience of male medical students in OBGYN, that they may feel socially excluded, or that patients may not want men in the delivery room. But actually what we are doing as physicians and educators is allowing some of these stereotypes to persist by providing more procedural experience to our male medical students. And Diana Pierre looked at this with me a couple years ago also, that in OBGYN conferences, that although women do present, there is a segregation of topics within obstetrics and gynecology conferences and meetings, where men do present more surgical presentations and abstracts, while women present more medical abstracts. And these two conferences on the end are international conferences. So at international meetings, that women are less likely to present, but the distribution of topics is more equal. And this, I think, speaks to how our social and cultural environment may be different depending on where we live. And the next domain of gender that I'm going to talk about is our gender relations, which are interpersonal interactions and group dynamics that are based upon attributed gender and are embedded in our relationships. And so this is a not medical slide or example, but this is an example from the lay press, where two people, Nicole and Martin, both worked in sales, and by accident their email signatures were swapped, and so they decided to take this as an experiment, and they each signed off on all their client emails as a person of a different gender. And you can see that for Martin, this was really profoundly eye-opening, that his 2 weeks were really very difficult. While Nicole reported that these 2 weeks were the easiest of her professional life. Gender relations influence how we are perceived as teachers and educators. This data comes from Rate My Professor, where you can see the blue dots are ratings of male teachers, and the orange dots are ratings of female teachers. And across the board, across multiple different fields and fields of teaching, men are perceived as being better teachers than women. Women receive lower evaluations across every discipline. Men are also more likely to be rated by their students as being genius or brilliant. And when you look at this compared to students' grades in later classes, the better professors actually had lower ratings from students, and the women actually, when you measure this in terms of what students learn and how they perform later on, the students who had women professors did better. This influences how we work in the operating room. The probability of cooperation is reduced when there are increasing percentages of men in an operating room. And when measuring team dynamics, there's significantly more cooperation in the room when the surgeon is not the same gender as the rest of the team. So as you know, most support staff in the operating room and most nurses are women. And so this really advantages teams where there's a male surgeon and the support staff is made up of women, and disadvantages women who are surgeons. And the worst possible scenario for women is when there are a woman surgeon with women staff. This leads to the lowest amount of cooperation in an operating room environment. And of course, this also has to do with referrals. For people in an academic faculty practice, referrals might not be the defining of salary, but for a lot of women, referrals are necessary in order to pay your bills or pay the rent or demonstrate productivity. And what we see across referral patterns is that men tend to refer to men and are much more likely to refer to men than women, and women refer to women, but only by a very small percentage. And so when a surgeon has a bad outcome or a patient suffers a complication, referrals actually drop by a third when the surgeon is a woman, but not if the surgeon is a man. And a bad outcome for a patient that is cared for by a surgeon who's a woman actually doesn't just affect that woman, it also leads to fewer referrals to all women in that referral pool. As you can see in this, the referrals to men are unchanged, but the referrals to women drop off. All women drop off after a complication. And so what do we do with this? All of these layers and domains of gender add up and accumulate and lead gendered power dynamics, which are systems of social inequities that are based upon gender that reproduce, shape, and control opportunities and experiences. And I just am introducing the term structural sexism because I think it's useful to think about how inequity in power and resources favor men within political, economic, and cultural institutions. And so when we think about power, I think there are two components to this. At least two components to this, but the two main components that I think about are status and money. And in this top picture comes from a graphic that from a a paper written by Molly Carnes a few years ago that is called Why Jennifer's Not Your Department Chair, which looked at status amongst medical specialties, and you can and what she posited was that in the more procedural or technical or male that a masculine that a specialty is, things like surgery or interventional cardiology, there's a lower percentage of women, and there is an increasing status that's associated with this. However, lower status specialties include things that involve the care of women or children, education or service. And so I think gynecology is really an outlier in this. And I want everybody to think about how gynecology is an outlier in this, because these perceptions may be changing how our specialty is practiced. We also see a very significant decline in salary by specialty. The more women that are in a field, for every 10% increase in a specialty that's made up of women, there's an $8,000 per year drop in mean salaries. And so I just want to spend a little time and dig into this to talk a little bit more about salary and the wage gap, because the wage gap is so reflective of how we're valued in our society. And I think most people, myself included, think about, when you hear, equal pay for equal work, you think about one man and one woman, and they're both working on a factory line, and they're doing identical work, but the man is getting paid $1 and the woman is getting paid 79 cents. But actually, gender wage gaps are much more complicated than that. It actually has to do with something called occupational segregation, which is the separation by gender into different professions. And so this has actually been very stable over time. This bar graph looks at the percentage of women and men in various professions since the 1970s. And you can see for things like teachers, librarians, like those are professions predominantly made up of women, and they have been over time, and that's been very stable. Other professions like engineering and lawyering has been typically performed by men, and actually physicians have the largest increase in women of all of the professions that have been looked at, where we're approaching 50% men and women. And so going back to the beginning of this presentation, when we talked about 30% being a critical mass where culture change happens, actually there's a fair amount of economic data that looks at 30% as something called a tipping point instead of a critical mass. So this is economics data looking at various professions over time and what happened when these professions became feminized. So these are professions like bank teller, bill and account collectors, ticket and station agents, typesetters and compositors. Some of these professions don't even exist anymore. But as the number as the percentage of men in these professions decreased and women entered these professions, both status and wages dropped dramatically. And so somewhere around 30%, when about 30% of the profession becomes women, you see this loss of value to the work that's being done. And this can actually be looked at across skill levels. So this is a complicated graph, but I'm going to focus your attention on the high skilled professions, or professions that require a higher education and professional school or education. And so amongst the high skilled professions, you can see that men that are working in female dominated professions, they look around and they are look at their colleagues and they say, oh, wow, I'm doing really pretty well. The men and women, we're all making the same amount of money. Men are making 100%, 101% of the salaries that women are making. When you look only amongst professions that are dominated by women. And I'm not going to get into this, but oftentimes with less education and less experience. When you look at women who are working in female-dominated occupations, however, those women are making 71% of what those women could be making if they were working in a male-dominated profession or a profession which is made up of mostly male workers. And the people that are the worst off in this whole graph actually are the high-skilled men that are working in female-dominated professions, because they're actually making only 2/3 of what they would be making if they were working in a male-dominated high-skilled profession. So for all of the gynecologists that are men that are looking around and think that they're doing pretty well financially, they could be making significantly more money if they were working as orthopedic surgeons or cardiothoracic surgeons. And specifically, you can look at this in the case of urology versus GYN. And Eileen Pelly from the University of Wisconsin did a really nice job putting this data together. This scatter plot graph looks at obstetrics and gynecology versus urology, and the graph looks at the percentage of women in an occupation compared to salaries, and you can see OBGYN and urology are at the opposite ends of the spectrum. The authors went a little bit further and looked at trends in salaries over time, and you can see in the mid-70s that OBGYNs made about 120% of the mean salary for physicians, and this persisted into the 80s, where urologists and OBGYNs were both paid about 20% more than the average physician. But by 2017, which was the next data point that they had with really good data, OBGYNs were at the mean, were making the same salary as the rest of physicians, whereas the salary, the increase in salary for urology has persisted. And so the authors put forward 3 theories for why this is happening, which I think it's worthwhile to go through. These theories explain gender wage gaps in the context of occupational segregation. And the first theory is one of equalizing, that women are choosing lower paying jobs or less work than their male colleagues. And actually, this is a myth that's really well, that's often passed around even within OBGYN. This is from the 2017 OBGYN workforce report, where ACOG put into print that any gender issues in compensation are caused by female OBGYNs desiring fewer hours and weeks. This is really not held up by the data, where the number of part-time faculty or OBGYNs working part-time by gender is really not, there's no difference. Men and women are equally likely to work part-time. The next theory is one of queuing, that men are favored by all employers and then are competing for better high paying jobs, leaving the lower paying jobs for women. However, this also doesn't really bear out to reality. Amongst all occupations, there's only 6% of occupations where women earn more than men on average. And so if this were true, we would expect the gender gap amongst lower paying occupations to have disappeared, or there be professions where women make more money than men. And the last theory that they put forward, which is what I would really like everyone to think about, is that the work that's done by women is systematically devalued over time. And so there is evidence for occupational segregation in OBGYN, as amongst surgical specialties, as described in this table that Caprice Greenberg presented in her sticky floors, glass ceilings presentation, as there are decreasing numbers of women within a surgical field, there are increasing salaries, with OBGYN being at the bottom and neurosurgery being at the top. And we see from a fair amount of data that that real salaries are actually declining in OBGYN. OBGYN salaries increased over this 5-year period by 2% and did not keep up with inflation. We know that there's data that women's health clinicians are doing more for less. Michelle Benoit updated Barbara Goff's data on what you get paid for procedures that are female specific in 2015, and Emma Barber updated this again more recently, but I left this in here. There are 84% of male-based procedures that are compensated by CMS at higher rates than the comparable female-specific procedures. And this difference is not insignificant. It's 27% higher pay. And there's been really the increase in female procedure-based work RVUs has not been seen over the last few decades. There are a few places where I think people are familiar with this, with decreases in compensation for hysterectomy, lymph node sampling, amongst others. And where we see this the most dramatically is when the patient and the surgeon are both women. There are two presentations. There's a publication and a presentation that both demonstrated looking at genital torsion, what the impact is on the patient, depending on whether the patient is male or female, and the surgeon is male or female. And so the longest delays, it was almost twice as long delays were seen for female patients who have a woman surgeon waiting for torsion, and the metric here was decision to incision time. So from the time that a decision is made to proceed to the operating room for torsion, the longest delays that were seen were for female patients with surgeons who were women. And over time, all of these small acts accumulate, and I could talk for hours about each one of these things, but we see these small gender biases across every single thing that happens in medicine in terms of electronic health record messaging, experiences of being unrecognized, microaggressions. Women in medicine, across medicine and OBGYN experience these events really daily. And the worst, what we all fear from this, is attrition from the workplace. And so there's data for this really in oncology, and I have not seen it in other fields, but I think this is probably representative. A few weeks ago, this data was published in the Journal of Oncology Practice, looking at attrition from the workforce over the last 5 years. 21% of the oncology workforce stopped practicing, and we've heard this anecdotally across other specialties. It was 22% of gynecologic oncologists that stopped practicing within the last 5 years. Of course, COVID exacerbated the rates of attrition for many people, but at every level of experience, attrition was more common for women than it was for men. And just one note on, because I don't want people to think that they shouldn't have women doctors. Despite all of these challenges, there's a wealth of data that women are providing high quality care, and arguably higher quality than their male colleagues. And because this is an OBGYN audience, and I get this question also all the time also, I just want to mention something about one more thing for the men, because people do think about this, and I think we all want our workforce to be diverse and inclusive, but actually men across professions are advantaged within female-dominated workplaces. So this data comes from Sweden, but within workplaces, the people most likely to be promoted or get raises are men who work in professions or in environments that are female dominated. And so I have a few more slides, and I know I could talk all day, but I'm going to run out of time, and I want to leave time for questions. So I'm going to briefly go through a couple good news and bad news and solutions for everybody. And I think the good news, and I think this is what the departments of OBGYN and the profession should really lean into, is OBGYN, as I mentioned in the very beginning, is the most diverse of all of the specialties in medicine. OBGYN faculties look more like the United States population than any other specialty, not just because of our inclusion of women, but also because of inclusion of underrepresented populations as well. The bad news about this is that inclusion does not create equity, as I hope I've made the case for. This is a paper looking at gender discrimination and sexual harassment amongst surgical residents. And for both discrimination and harassment, as the number of women in a surgical residency increases, so do reports and acts of discrimination and harassment. And putting more women into leadership positions just in and of itself does not create equity. A few years ago, we looked at a survey of gynocs. We surveyed gynocs about their experiences of discrimination and harassment. And just having a woman in a division director or chair position did not mean that women had less of these experiences. And this is because we all live within a social environment. Acts of discrimination are coming from peers, patients, hospital administrators, staff, and nursing. And so to move forward, I think one of the key aspects to moving forward is thinking about transparency. This is a list of metrics to consider that that can be made transparent from a publication this year by Julie Silver, looking at how really giving direct advice on how to measure gender equity and implement it. We also in OBGYN really have to acknowledge our past. We were a specialty formed in a Victorian era and formed in the and changed dramatically in the 1970s by the feminist movement. And when I was a resident, we still walked out when the labor floor was quiet to look at the statue of Marion Sims in Central Park. And hopefully people know or can look up the statues in Alabama that are in honor of the slaves that Marion Sims experimented on. We can reimagine our institutions. This is a recent publication looking at ways that institutions' leadership, recruiting, job changes, and success can be measured, and it's a play upon an older 1990s publication looking at how the institution does not love you back, and I think this is ripe for change. We also can change how we think about leadership. Most people, when they think of a leader or have to draw a picture of a leader, draw a man and a white man, and it doesn't have to be like that. We can actively change how we think about who is suited for leadership. We have to have zero tolerance for sexual harassment and discrimination. For sexual harassment and discrimination in environments where harassment and discrimination are permissible. These are environments that inequities thrive, and this is really, really critical to changing our culture. One word about mentorship and sponsorship. This is critical. This is the one intervention that has been demonstrated to improve women being promoted and moving into leadership positions. We have to raise our expectations of everyone. Everyone in a community benefits from having higher standards, and we're so lucky in medicine that we can align our incentives around patient care. And I think this is my last slide, but if people want to read one article about how to change culture, I'm going to refer them to this article by Reshma Jagsi, talking about how to be an upstander or a person who speaks or acts in support of an individual cause, or a person who's being bullied or attacked. And what I like so much about this paper is that it gives very concrete ways to react in a particular moment, depending on your comfort level in the situation, and including how good or bad of a sense of humor you have to the situation, which I think is very useful. And just lastly, we have to have multi-pronged approaches to culture change. This doesn't happen overnight, and it doesn't happen from one intervention. There need to be multiple interventions and buy-in from everybody. And I think with that, I will ask for questions.
Thank you, Dr. Temkin. I see that Dr. Bayat has her hand up.
Hi, good morning. My name is Lily, and I'm one of our family planning doctors. So feminism is obviously the thing that motivates me the most. So thank you so much for this presentation. It was really wonderful. I have kind of a comment that's going to lead to a question. I think that, you know, whenever we're considering gender dynamics, we have to keep in mind that gender doesn't operate in a vacuum, and that even just considering the experience of women have different experiences, and we have power hierarchies and structures within women working with women, right? All women don't have the same experience. And I think that in order for us to really achieve progress towards actual equity in, you know, in our field, we have to take into consideration their power dynamics amongst women between, you know, white women and women of color, and that those power dynamics tend to you know, benefit white women at the expense of women of color. So I just think it's really important for us to understand that it's not just male and female, right? Even in our community of women, it's so much more complicated than that. And I think in particular, in light of the Supreme Court decision, you know, about affirmative action, I think this is going to be a really, really big issue that as we really have to be united on. And I'm wondering if you can talk a little bit about, you know, the experience or sort of how this impacts women of color more than women, you know, than white women, because I feel like feminism in general has been very white centric. And so I'm, you know, hoping that you can speak a little bit about how it might be different for women of color.
Yeah, thanks. Thank you so much for the question. I mean, I think that really resonates a lot with a lot of people, and I think this is, you know, I have extra slides on intersectionality that, just in the interest of time and making, you know, the point about structural sexism, I just don't have the time to go into all of those details, but yes, this is absolutely a problem, and intersectionality has to be considered. There are unique challenges, and unfortunately, there is an entire dynamic where women are rewarded for playing their part in, you know, historically sexist structures, and certain women are rewarded for that. And so, you know, I think this is important for all of us to think about how our behaviors influence not just influence not just women, but women and men and all women. And it's not meant to be, this talk is definitely not meant to be exclusive to white women. I don't know if I answered your question.
I see that Dr. Gerda has her hand up. Dr. Gerda, we see your microphone went green, but we can't hear you. It's not a mute problem, we just can't hear you. All right, Dr. Ayers, why don't you go ahead while we wait for Dr. Gerda to get her connection?
Well, thank you very much. That was very impactful. And I think you answered part what Dr. Bayat had said. I am Assistant Dean for Multicultural Affairs as well as Vice Chair of the department. And one of the things that when you're at that table, and we know that this is really a culture change, right? And I appreciate you saying that inclusion doesn't equal equity, right? We're included at that table. But if you could just say two things that probably would move us or be impactful to help do that change, because we do a lot of talking and your data was amazing. Thank you so much, because that helps. I'm really data driven. But when you've gone around the country or spoken to other people, what have you found for them to say has been impactful as they've tried to move that change, try to move that needle?
Oh gosh, you're going to try and make me be optimistic. I think like
We have
I
to though,
I
right?
think I
So
want. I know. I mean, I think I think there's a lot of pieces. I think that we're so privileged in OBGYN to have this opportunity, right? Like we're the first specialty that have had this inclusion of multicultural, multi-ethnic, gender inclusive workforce, right? Like we should be leading all of medicine in terms of showing people to how to how to change culture and make our medical cultures more equitable for everybody. It's good for us, it's good for the patients, and I think, you know, it's maybe a don't instead of a do, but what I think people talk about is like just bringing people into leadership positions but not supporting them is not helpful. It's not helpful to the field. It's not helpful for when that OBGYN leader goes to a hospital committee and is the only woman and the only person of color at that table and is in their department. That does not help. That doesn't help medicine change. It doesn't help our specialty, and it definitely doesn't help our patients. We see such drastic disparities, racial disparities in female specific conditions, in pregnancy and fibroids, endometrial cancer, that are bigger racial disparities than in any other condition in other conditions in medicine, right? And I would say that race is so important in that, but so is structural sexism, right? If we're not coming to the table bringing high quality care to our female patients and to the women that we take care of, then we are not in a position to combat any of these other isms also.
I see that Dr. Sharma has her hand up and we only have 2 minutes left.
Well, firstly, I would like to thank you, Dr. Temkin, for this, very thought-provoking talk. And I mean, you showed the data and data speaks for itself, but I want to focus more on the answers, like what can we do? So is it just the awareness generation that that you just did, or is it or can we just, because we are more collaborative and we are more team players and keep working, do we need more negotiation training? to advocate for
No,
ourselves?
definitely don't,
Or
no. I mean, women are so good at negotiating, right? Like we negotiate all of these barriers and we negotiate all these things. And then you go to a class and you're told like, oh, you're terrible at negotiating. We're going to teach you. Like that's not, we all as a community have to change what we value, right? One of the reasons that women provide arguably higher quality care than men is because you've had to learn to work around all of these, the nurse doesn't give you your equipment and you're this, and your patient doesn't automatically assume you're competent. And so we have to shift the way that we think to value these things. I think negotiation should be, you can't negotiate with terrorists, right? Like the hospital has to like accept that women are valuable and they should want to negotiate with you, right? Like we have to find ways to advocate as a collective for better treatment and for the things that make our patients do better being valued.
I personally think, I mean, objective measures like in basically what you just, I think, touched on briefly was promoting more transparency, right? That around the wages, what are the opportunities being given for professional and personal growth for different sexes in the department. You could. So I think more transparency is a big thing, and that could help.
And I just want to underline that those things are good, not just for the women, but they're good for men. We see this over and over again in situations of inequity. When you make the environment more supportive, the biggest benefit is for the person who's underprivileged, but the entire community benefits.
All right. Well, I'm very sorry, but we're out of time and we are not allowed to run over. So Dr. Temkin, I just want to thank you again for this excellent talk.
Thanks for having me.
Thank you.
All right. Thank you, everyone.